So, in our talk about the radial head and neck fractures, we will start with an introduction. So, the radial head and neck fractures are the most common fractures of the elbow joint. And these fractures could be isolated or they could be associated with elbow instability, or they could be associated with mechanical block to the elbow motion. And elbow motion means the movements that the elbow joint can do, like flexion and extension, and pronation and supination. They also could be associated with an injury to the distal radio-ulnar joint, and they could be associated with an injury to the interosseous membrane. And these fractures are diagnosed clinically and by plain radiographs and treated non-operatively or operatively depending on many factors. Moving on to talk about the mechanism of injury. So the radial head and neck fractures are mostly caused by a fall on the elbow or a direct trauma to the elbow joint, or they could be also caused by a fall on the outstretched hand with the elbow extended and the forearm pronated. And to really understand these injuries, first we have to understand the anatomy of the proximal radius. So the radius is the lateral and shorter forearm bone. So the radius is on the lateral side of the forearm, and in this picture the radius is this bone on the lateral side. And the proximal end of the radius composed of a short head and a neck and a medially directed tuberosity. So again, in this picture we have the radial head here, and below it is the radial neck here, and a medially directed tuberosity that you can see right here. And the radial head articulates with the capitulum of the humerus proximally to form the radiocapitular joint, and it also articulates with the radial notch of the ulna medially to form the proximal radio-ulnar joint. So the radial head here articulates with the capitulum of the humerus to form the radiocapitular joint, which is part of the elbow joint, and it also articulates with the ulnar notch here to form the proximal radio-ulnar joint. Now, the radial tuberosity is where the biceps tendon inserts. So the biceps tendon inserts here, and the shaft of the radius gradually becomes bigger and bigger as it passes distally, and that is opposite to the ulna. So the shaft of the radius becomes bigger and bigger as it moves distally. So as you can see, it gets bigger and bigger as it moves distally, and this is opposite to the ulna because the shaft of the ulna becomes smaller and smaller as it moves distally. Now let's talk about the classification. So the radial head and neck fractures are classified according to the Mason classification. The Mason classification is the most commonly used classification for the radial head and neck fractures, and the Mason classification was modified multiple times by Hotchkiss and Broberg-Mori, and now it is on 4 types. So type 1, type 2, type 3, and type 4. So starting with the type 1, so for a radial head or neck fracture to be classified as type 1, it must be non-displaced or minimally displaced for less than 2 millimeters. And there is no mechanical block to pronation and supination. And as you can see in this picture here, on the left picture, we have a minimally displaced radial head fracture, and on the right picture, we have a minimally displaced radial neck fracture. Type 2 comes next. In type 2, the fracture is displaced for more than 2 millimeters or angulated, and there is possible mechanical block to pronation and supination. And as you can see on the left picture here, we have a displaced radial head fracture, and on the right picture, we have a displaced radial neck fracture. And type 3 comes after, and in type 3, the fracture is comminuted and displaced, and there is always mechanical block to pronation and supination. And as you can see in this picture here, we have a comminuted fracture, and it's also associated with a mechanical block to pronation and supination. Now in type 1, we have no mechanical block to pronation or supination. In type 2, we have a possible block, and in type 3, we always have a block to pronation and supination. And lastly is type 4. So in type 4, we have any radial head fracture, so any of the previous types with elbow dislocation. So if we have an elbow dislocation, this would make the injury into type 4. Now let's talk about the clinical features. So regarding the symptoms the patient complaining of, so those include that the patient present with elbow pain, and they also complain that they can't rotate their forearm. Regarding physical examination, so on looking, the elbow might be swollen, and there might be ecchymosis, and deformity is present if there is associated elbow dislocation. On feeling, there is tenderness on pressure over the radial head, and pain at the distal radio-ulnar joint is suggestive of an Essex Lopresti fracture dislocation, which will be explained later. So make sure to palpate the distal radio-ulnar joint to make sure that there is no pain and the Essex Lopresti fracture is excluded. Regarding moving, so you assess the range of movement of the elbow, and it is important to check for mechanical block, and that is done using the local anesthesia test. Because the patient in pain, so most of the times they can't move their elbow, so that is why you use the local anesthesia test. You inject local anesthetic in the joint, and then you passively move the joint, assessing flexion extension and pronation supination, looking for mechanical block. Now let's talk about the imaging. So imaging in radial head and neck fractures, we use anteroposterior and lateral elbow x-rays. Those are ordered routinely, and there might be a clear abnormality on these radiographs, or sometimes both views are normal in occult and displaced fractures. Sometimes we order CT or MRI, which can help better understand the injury and plan the operative management. And on this x-ray that you can see right here is an AB elbow x-ray, and it shows a radial head fracture. It's an intra-articular, minimally displaced radial head fracture. Now let's talk about the associated injuries. So in radial head and neck fractures, we have associated injuries like a lateral or a medial collateral ligament injuries, and the lateral collateral ligament is the most common to be injured in 80% of the cases. And we might also have other fractures like coronoid process fractures, olecranon fractures, and carpal fractures. And we may also have the Essex Lopresti injury, or the Monteggia fracture dislocation, or the terrible triad injury. Now regarding the Essex Lopresti injury, so this injury is a combination of a radial head fracture and an injury to the distal radio-ulnar joint and an interosseous membrane injury. And this injury can result in a progressive forearm displacement and usually requires surgical treatment. And one of the treatment options for the radial head fractures is the radial head excision, and the radial head excision can't be done if this injury is present. So the radial head excision is contraindicated in Essex Lopresti injury because it would result in secondary wrist problems. Another associated injury is the Monteggia fracture dislocation. So in Monteggia, we have a combination of a radial head dislocation with or without radial head fracture and a proximal ulnar fracture. So we have a problem in the proximal radius and we have a problem in the proximal ulna. And in this injury, the radial head excision can't be done too because it would lead to elbow instability. We also have the terrible triad injury. So in the terrible triad injury, it's a combination of a radial head fracture with ulnar coronoid process fracture and an elbow dislocation. Now let's talk about the treatment. So in radial head and neck fractures, we either treat them non-operatively or operatively. Starting with non-operative treatment, so the indications of non-operative treatment include most of the isolated fractures and the Mason type bond fractures, which are the non-displaced or the minimally displaced fractures with no mechanical block to forearm rotation. And indications of non-operative treatment also include the Mason type 2 fractures that are not associated with the block to the forearm rotation, meaning the non-operative treatment is indicated for all the fractures that are not associated with blocking to the forearm rotation. And the fracture is immobilized by a sling for 1 week, and movement is started after to prevent stiffness, and reassessment by X-rays to make sure no further displacement occurred. So the X-rays is retaken after a few days to make sure no further displacement occurred. And exercises are started as soon as possible, and the patient are advised to move the arm freely within the limits of comfort to prevent stiffness. And there is loss of the last 5 to 10 degrees of elbow extension in most cases, and that is due to stiffness, and the prognosis is good in 90% of the patients. Moving on to the operative treatment, so the indications of operative treatment include the Mason type 2 fractures with mechanical block to forearm rotation, and the Mason type 3 fractures, and when there is persistent radiocapitellar crepitus or pain after the non-operative treatment. And the operative treatment options include open reduction, internal fixation of the radial head and neck, and they also include fragment excision, prosthetic replacement, and radial head excision, which is suitable for older patients with low demand. Now, the fractures with 2 substantial head fragments are best fixated with open reduction and internal fixation, while more comminuted fractures are treated with either prosthetic replacement or radial head excision. And the fragment excision is indicated when there is joint obstruction with a small fragment that is too small to be fixated. So if the fragment is too small to be fixated, then it is excised. And in the presence of other injuries like the Monteggia and the Essex Lopresti, or where there is suspicion of elbow instability, then the radial head excision is contraindicated, and the open reduction internal fixation or the prosthetic replacement has to be done. And elbow instability is suspected when there is loss of the cortical contact of the radial head fragment or a fragment that is greater than a quarter of the radial head surface, and in this case the fragment should be reduced and fixated. And in all operative cases associated with lateral ligament avulsion, this injury should be treated with suture anchor repair back to the humerus. Finally, let's talk about the complications. So one of the most common complications is the elbow stiffness. So in elbow stiffness, there is loss of elbow range of motion, mostly the last 5 to 10 degrees of elbow extension occur in most cases. And stiffness is caused by capsular contractures and ossification, and it is also caused by the hardware that is used in the fixation of the fracture. Another complication is the post-traumatic arthritis. So this complication occurs due to some incongruity that remained between the joint surfaces, and it is a late complication, and the patient complains of pain and restriction of movement, and it is treated with radial head excision. Other complications include malunion and non-union, and elbow instability, and surgical site infection, and secondary displacement. So after non-operative or operative treatment, there might be secondary displacement as a complication. And another complication is posterior interosseous nerve injury secondary to the operation. And with that, we reach the end of this video. Thank you guys for watching. Please like this video and comment your ideas and questions. And this video is a part of a bigger class. It is called the Elbow and Forearm Trauma Masterclass. Please check it out. Link in the description.